a couple more people come on in the next few minutes. But hey, everyone, I'm Ariana, one of the organizers of this group. Thank you for coming today. Today we have Dr. Connor ONeill with us. I'm super excited to have him here. Dr. ONeill is going to be speaking to us about chronic low back pain. So just a bit about Dr. ONeill. He specializes in diagnostic and non-surgical treatment for patients with chronic back and neck pain. He's board certified in internal medicine, anesthesiology, and pain management, and he's an active researcher as well. So we're really grateful to have him here, just such a diverse and thorough background. So yeah, you can take it away, Dr. ONeill.
Okay, great, thanks. Yeah, I'm really happy to be talking to you guys. I hope some of you get interested in PM&R and take it to the next level, make it your career. But even if you don't, chronic low back pain is such a common condition that everyone, almost no matter what specialty you're in, maybe with the exception of pathology or something like that, is going to have to deal with it at some point. So hopefully you'll get something out of this. So, I mean, chronic low back pain diagnosis and treatment can be extremely complicated. Sorry, to figure out how to advance my, nope. Oh, there we go. Okay. But not always. There's I think a famous saying from Sir William Osler that sometimes just have to listen to the patient to tell you the diagnosis. This was a case of that. This is a 31-year-old gentleman who came in with chief complaint of it, and I'm quoting him, "It feels like I have a knife in my back." And it turns out he did, actually. This little thing down here is a tip of a knife. He'd been stabbed in his back a few months before, and the tip broke off, and he was still carrying that around with him. So that's a fairly straightforward case to diagnose and treat. But most of the time, it's not like that. So when we're faced with a patient with low back pain, the first goal is to determine of these patients with low back pain, which ones have a serious condition that's going to require oftentimes some type of invasive treatment. That's going to be about 10% of people. And the conditions that we're most concerned about are what we call red flag conditions, which are over here. The remaining patients, 90%, are going to fall into this category of non-specific low back pain. So these are the ones that really eat up most of our time and resources. But it's important in anyone's practice, if you're seeing back pain patients, to make sure that you're aware of these very serious conditions that are going to warrant, a more intensive level of care. And basically, these are tumor, infection, fracture. CES stands for Cauda-Equina syndrome, nerve root syndromes. And when I say nerve root syndromes, I mean nerve root syndromes that are causing a functional problem, such as a foot drop or inability to walk or ambulate in some manner. And finally, there's rheumatologic conditions, autoimmune disorders such as ankylosing spondylitis and other similar conditions that we have to be aware of. So if we've ruled out all those things, then the patient really falls into this category of non-specific low back pain. But before we talk about that large group, I just want to go through some examples of some patients that had these other conditions. This is a young man who's a 28-year-old who came in with acute onset low back pain after snowboarding. And so it seemed at first like just a simple strain, but his symptoms persisted for several weeks without change, which led to an MRI scan. And I think you can probably appreciate this what we call a marrow replacing lesion here. So this turned out to be lymphoma. So he actually went on and got successfully treated. But this is an example, obviously, of a red flank condition of tumor that's initially presenting as what seems like just run-of-the-mill low back pain. Okay. This is an older woman. She was in her 60s. She came in with sort of classic back and leg pain to, would suggest some type of nerve or irritation problem. If you look at her MRI scan, there's some sort of typical age-related degenerative changes. This is spinal canal. These little wispy things are nerve roots here, so there's nothing that looks like it's compressing a nerve root to explain her pain. Here's what we call a sagittal image that shows the nerve roots again, these dots here surrounded by white, which is fat. So everything looks pretty good. But then if you look up here, you see this little blob up here, and that ends up actually being a tumor. In this case, she ended up having a primary brain tumor. This is what's called a drop metastasis, where a met sort of filters its way down through the meninges and lodges in the cauda equina. In the conus medullaris, and mimicked typical degenerative type low back pain. So that's another example of a patient presenting with a low back pain that turns out to be something serious, namely a tumor. This is a young woman in her 30s who came in with thoracic pain. So this is what her pain diagram looked like. Had some fairly classic mechanical features, which we'll talk about in a few minutes. But again, she went through physical therapy. Some other conservative treatments didn't get better. This led to an MRI scan of her thoracic spine, which is essentially normal. And in her case, she ended up having a big hepatocellular carcinoma. She was hepatitis B positive and had sort of probably chronic hepatitis B infection, turned into a liver cancer. So these are diagnoses that you definitely have to keep in the back of your mind. So even in young patients that don't have histories of cancer or other risk factors, if they're not responding to treatment, you need to always think of these less common causes of pain. This is another classic case of pain due to a specific thing we can treat. This is an infection, and you see this whitish stuff here. This is indicates intense fluid accumulation. This is in the disc, and you see the whitish stuff in the bones as well. That indicates spread of inflammation into the adjacent bones. So this is a case of discitis / osteomyelitis. Most common in people that are immunosuppressed or IV drug abusers, but can occur in other people as well, just spontaneously. In terms of fractures, the thing we see most commonly is a compression fracture. This is something you have to always keep in mind with elderly patients, particularly if they have acute onset pain. This is on a radiograph, a compression fracture. Here you can obviously see this is basically a pancaked vertebral body. These are very painful. They're usually not dangerous. This is an MRI scan of the same patient, and here's where the fracture is. And you can see that when things sort of flatten down, you can get what we call retropulsion, or bone gets pushed out the back and can impinge on the spinal cord and cause neurologic compromise. That's pretty uncommon, but certainly something to keep in mind when you see elderly patients with acute back pain. So we mentioned briefly nerve root syndromes before. This is a patient who, this is a lumbar disc herniation, which you can see on the sagittal image here, this little thing sort of pooching out. And on the axial view, this is the disc here. This is that same disc herniation pushing out. These little dots here, these little gray dots, are nerve roots. And you can see on this side, there should be a nerve root, matching nerve root here. You should see it over here, and you don't really see it because it's being compressed by the disc. So this is an example of a back problem that can result in nerve root dysfunction, and in severe cases, weakness. It's quite uncommon though. Most patients with disc herniations do not get weakness. Their most common presentation is pain. So you can have a very large disc herniation and have very little in the way of weakness. So just the fact that someone has a disc herniation is not a scary thing. The more important issue is if they have weakness to the point where they can't ambulate in particular, that's something you have to take very seriously. Caudate Aquinas syndrome is the most, I guess, severe form of neural compression. That would typically occur with massive disc herniations that just obliterate the whole spinal canal. And those patients present with saddle anesthesia, urinary retention, weakness, obviously. So those are questions that in general you want to ask of patients with back pain, just to make sure that there's no no suggestion that they have some serious problem like that. But most of the time, disc herniations are benign. Patients get over them on their own, and they don't cause serious problems. The other condition that can cause nerve root problems, in particular weakness, is spinal stenosis. So here you see on this slide here, we have, these are the bones, these are the discs in between, and this is the spinal canal. And you can appreciate that here at this one level, there's substantial narrowing of the spinal canal. And here you see these little dots here are nerve roots. And if you compare to the last image, the amount of CSF is really minimal. The nerve roots are really squeezed together. So this is a patient with spinal stenosis. Now, things interesting about stenosis is even though there's a markedly diminished spinal canal, these patients rarely have weakness of any kind. They more commonly present with just pain. And you can have a severely stenotic canal and actually minimal, if any, pain whatsoever. And vice versa, you can have a relatively modest amount of stenosis and severe pain. So there's something else about stenosis other than the compression of the nerves that seems to lead to pain, probably inflammatory. And it's also an indication that things that develop slowly over time, the nervous system is really able to adapt to. And it's actually pretty amazing when you see images of patients with severe neurocompromise and absolutely no symptoms. So I think the real problems tend to occur with sudden acute changes that the nervous system can't adapt to. Finally, in terms of red flag conditions, you want to keep in mind autoimmune disorders such as ankylosing spondylitis. Classically, this would appear as pain in the sacroiliac region. This is from a young man who came in with low back pain that turned out to be ankylosing spondylitis. And this is his sacroiliac joint here, and you can see this whitish appearance of the bone marrow, and a little bit on this side. This is inflammation related to an autoimmune process affecting the sacroiliac joint. And these patients typically are HLA-B27 positive. So the normal workup is to do HLA-B27 typing, look for inflammatory markers like sedimentation rate and C-reactive protein, and just be particularly aware of this possibility for young patients that come in that have back pain. There's certain features that go along with inflammatory back pain we won't get into here, but for young people, it's important to keep that in the back of your mind. So I think some of you, depending on the point you're at in your training, may or may not have heard of red flags. And there's a whole series of questions that typically one asks to see if patients are at risk for one of these serious conditions. And if if this has been looked at critically a few different times actually, and they're not as useful as we might think they are. Certainly, if they're negative, that doesn't mean that a patient doesn't have one of these conditions. And I think one thing I would really keep in mind is that probably more important than how patients respond to these different questions is how their condition evolves over time. And if you have a patient that does not respond to conservative treatment, definitely, should sort of rethink some of these other possible diagnoses. And if you haven't got an MRI scan, that's usually the first step. Any questions about any of those red flag conditions from anyone in the group? I'm assuming you guys are going to interrupt me whenever you have a question.
Oh, a lot of times, a lot of times we ask questions at the end, but if anyone does have a question, feel free to speak out.
Okay, all right, that's fine. Yeah, I'm totally fine. Just interrupt me, that's fine. So let's assume then that we've eliminated all these very serious conditions. We're left with this big bucket of patients that we call nonspecific low back pain. So these are some of the treatments for nonspecific low back pain. There's many more actually. And the problem with almost all of these is that even if there is evidence supporting them, the treatment effects are typically very small. So they do, at least at a population level, they are a very limited effect sizes, particularly if you compare them to placebo. They're even worse. But one of the big challenges we face is that even though on a population level, many of these are not very effective, there are individual patients that might respond extremely well to one of these various treatments. So that's one of the challenges that we face that we're going to talk about a little bit later when we talk about some of the research we're doing here. Because we don't know for sure which patients are going to help, which treatments are going to help which patients, and how to sort of design a personalized algorithm for them. What happens is that this is a very common path for patients to take. They come in, they see their primary care doctor. Depending on the primary care doctor's sort of referral habits or other factors, they may just go through this sort of like a ping pong ball bouncing around between all these different modalities. Each specialty has their own pet treatments they like. There's no evidence to support one versus the other, and it's not uncommon that the patient kind of comes out at the other end with the same problem they went in with. So this is a very common problem among low back pain patients. And I think one way certainly to help conceptualize nonspecific low back pain and perhaps explain why it is that the treatment responses are so varied, and in fact generally poor, is this. It's a classic biopsychosocial condition where you have a patient's pain experience is influenced by multiple different factors. And I think this is, I'm assuming you guys have talked about this even as first-year medical students, the biopsychosocial model, because it applies to a lot of different diseases. The basic concept is that for any particular condition, there's biological factors that play a role, there's psychological factors, and this is a particular issue with chronic low back pain in that negative thoughts and emotions are almost always a part of the pain experience for patients with low back pain. And then of course, social factors play a huge role in this disease, just as they do with many others. So that's sort of a conceptual model, but it doesn't help that much when you're actually in clinic and trying to figure out what to do with patients. So this is sort of how I think of things from a mechanistic standpoint when I see patients with back pain. Is first of all, is there some tissue damage or sometimes more importantly dysfunction that's actually triggering their pain? Something that's happening in the periphery that's activating nociceptors and triggering pain. So how much of their pain is due to that versus altered pain processing? And this is super important to understand, in that the final pain experience that someone has is going to depend upon what triggers are activated in the periphery and how the nervous system processes those and ultimately results in a pain perception. And just like all senses, perceptions arise in the brain, in the cortex. So there's a signal processing that takes place that's going to influence what the final perception is. So trying to break it into those buckets and trying to figure out how much is due to tissue issues and how much to their individual's pain processing. The problem is that assessing an individual's pain processing is pretty difficult, but there's a few things you can use, which we'll talk about. The greatest emphasis that most patients and many doctors put on when they're evaluating low back pain is what the MRI scan shows. And this is, many people have the assumption that if we can identify something, some tissue problem, that we've identified the source of pain. And you would think that enough time has passed now in our understanding of pain that we'd get away from this, but it's highly prevalent. And this is an example of what some places, Sutter in particular, what they do with their MRI reports, and they point out in their report that many of the findings that are described in radiology reports have probably nothing at all to do with pain. And this is based upon vast body of literature that's looked at MRI scans in asymptomatic people and comparing them to findings in symptomatic populations. So if you see in the second grouping there, all these different findings, disc height loss, stenosis, fissures, et cetera, that many patients and quite a few doctors sort of pick up on and sort of catastrophize about are really just normal findings that anyone gets as they age and don't have anything to do with pain. So that's one sort of major hurdle we face in treating these patients, is a lot of people really emphasize the tissue damage aspect rather than the pain processing. So acute pain, is pretty straightforward. If you break your finger, there's a message that nociceptors get activated. They send a message to the dorsal horn in your spinal cord, and then ultimately it goes to the cortex, and that's where pain perceptions arise. So that's a pretty straightforward and well understood process. What's much less well understood is what happens to the nervous system when it becomes sensitized. And so basically, under a whole variety of conditions, which we'll talk about in just a moment, the nervous system doesn't behave like it does in this acute pain scenario. So what happens is the whole system gets sensitized, so that the system, if you think of the system as a whole, it can be brought to threshold at much lower levels of intensity. And so even, simple innocuous, what would normally be innocuous signals that might, in a normal circumstance, just give rise to a little bit of ache or in a joint or pain in your back, for example, or stiffness, something you can deal with, gets amplified, and the nervous system responds with what's a much more vigorous pain response. And there's a number of conditions that are associated with this heightened sensitivity of the nervous system. First of all, there's a number of constitutional. First of all, it can be constitutional, and that's commonly seen with this group of conditions that are called chronic overlapping pain conditions. And it's thought that there's some underlying sensitivity in the nervous system that is responsible for, or sort of is the driver for many of these conditions, such as migraines, irritable bowel syndrome, interstitial cystitis, TMJ syndrome. So they're all conditions that we think result from relatively minor triggers in the periphery that the normal nervous system would sort of interpret as being non-threatening and not give rise to a pain response, whereas in patients with this constitutional sensitivity to pain, they result in these various conditions. So it's very important when you're seeing chronic low back pain patients to ask them about these different conditions, because if they do have one of these chronic overlapping pain conditions, then any efforts to, treat some specific problem in their back, for example, is probably doomed to failure. And this alteration in pain processing can also be acquired. And just any kind of chronic pain by itself can sensitize the nervous system. Psychological distress, absolutely no doubt about it. Narcotics, one of the things we've understood more and more over the last several years is that chronic narcotics actually result in this paradoxical hypersensitivity to pain. And oftentimes, if you can convince patients that are on chronic narcotics to get off of them, which is not an easy task by any means, they many times will actually find that their pain improves because of this improvement in their overall pain sensitivity. So given this, if you're seeing a patient in clinic, how do you sort of assess them? How can you really parse out how much of their problem might be in their back versus the nervous system? So there are some simple ways. One is with just a pain diagram or talking to them. This is a patient with pain marks over his whole body, essentially. And so he has really multi-site pain. And so we've become more and more aware that patients that have, pain in multiple sites, most commonly it's sort of widespread musculoskeletal pain, but also many times people will also have a visceral pain such as abdominal pain or pelvic pain. That this is probably more a reflection of a altered nervous system characteristics rather than some discrete pain problem in their spine. The other thing that's super important that is totally overlooked, and I shouldn't say totally, but almost totally overlooked, is just simple findings on physical examination. Of course, when you're examining a spine patient, everyone always checks their reflexes and their motor function and their sensory, et cetera. But the great majority of patients that you see with low back pain are not going to have anything wrong with their nerve function. But they are going to have impairments in their movement. And this is something you can pick up on exam just by asking them to move their spine. So this is from a paper from a very well-known low back pain researcher named Peter O'Sullivan. But it's important just to have your patients bend and forwards and backwards and just see what happens to their movement. If they have a very, if they have what we call mechanical pain, which means it's pain due to some mechanical dysfunction in their spine, they're going to have a pattern on exam of preference for one direction or another. So they may get more pain when they flex, they may get more pain when they extend, perhaps with side bending, but they'll have a classic pattern that reflects some type of change in what's happening in their spine as they subject different elements of their spine to alterations in loading. So if differential loading of their spine doesn't affect their pain, then the chance that there's some specific factor in their spine that's causing their pain becomes much less. So, and the other thing that's really important is to, in all patients that you are evaluating with chronic low back pain, is to try and probe at least some of the basics about their thoughts and beliefs about their pain. Because again, the more that they have negative thoughts and emotions, the more likely they are to be dealing with a sensitized nervous system that you may or may not be able to help, or at least it's going to direct how you might treat them. And there's some simple tools for doing this, for assessing patients in this way. This is one that's called the Start Back tool, which was developed many years ago, not many years ago, but several years ago, and it's become very widespread. We use this in our clinic. And if you see these, there's 4 It's a pretty simple tool, just nine questions. Most of them are yes, no. If you look at these four ones that are highlighted here, there's four sort of key attributes that this tool can be used to identify. The number 5 is not safe for a person with a condition like mine to be physically active. So that's assesses what's called fear avoidance. So some people are just so afraid that they're going to damage themselves if they move or are active in any ways that they avoid it. And that usually is bad for your spine because it results in deconditioning and a whole cascade of negative consequences. Number 6 is about worrying thoughts, so that gets anxiety. The more anxious you are, the less likely you are to get better. Number 7 is catastrophization. I always had trouble pronouncing that. And that's the thought that you're never going to get better. Your back pain's always going to be there. It's terrible, and you're doomed for the rest of your life. And some people just have that trait that they get pain, and that's how they think. And getting those people better definitely requires some attention to reversing these kinds of maladaptive thoughts. And number 8, really relates to depression. It's a screening question for depression. So, ideally, I mean, there are surveys that are much more detailed and much more precise, more responsive for identifying these different traits: fear avoidance, catastrophic thinking, anxiety, depression. But in a busy clinic, they're hard to implement. So, if you at least sort of ask these questions, or at least keep these 4 things in mind while you're evaluating patients, I think it's be super helpful.
Hi, Dr. Bill, really quick. Can I ask
Yep,
a question?
of course, yeah.
Yeah, a couple of the students were wondering if you could explain the difference between X and O from a couple slides ago.
X and O. X. Oh, this one?
Yes.
Oh, okay. So most pain diagrams, you ask people to fill out an X for pain and an O for numbness and tingling.
Okay, perfect. Thank you.
Yeah, yeah. So given all that, how do we approach most patients with low back pain? So this is sort of a treatment algorithm that's, I think, sort of widely accepted. That most people are going to want to stratify patients in some manner or another. And we use the start back tool. This is pretty well validated in the literature now. And so patients are assigned into various risk categories based on the start back tool, and that's used to inform their conservative care. Patients that are low risk, in other words, they have relatively low pain levels, they don't have multi-site pain, they don't have negative thoughts and emotions, they can need to be managed with low-touch interventions such as just home exercises. Patients that are more impaired or have some psychosocial issues, although not overwhelming, they're going to need some type of supervised exercise with a physical therapist or other type of therapist. And then patients that fall in the high-risk category where they really have a lot of these negative thoughts and emotions, they need not only supervised exercise, but also, some type of retraining with cognitive behavioral therapy. There's a whole variety of other sort of psychological methods that are used. CBT is probably the most common to sort of get them to reframe their thinking about their pain and to that's going to help in their recovery process. So if patients get through this conservative care program, which can include exercise, sometimes medications, acupuncture, massage, all these various complementary therapies. At some point, they're going to reach a point where we've said they're a success, in which case they can go on to some type of maintenance program. But oftentimes they're not, and so we've tried all the simple, non-invasive things, and it comes to a decision point. Is this someone that we think that we need to, that may respond to some type of interventional treatment? And these are people where that we think in our judgment that they either have clinical, hopefully clinical and imaging findings that indicate some type of tissue damage or dysfunction that's really the primary source of their pain. This is not a altered pain processing problem. It's really they have some structural problem in their spine that we can maybe treat with an intervention of some kind. So this is where there's really minimal evidence in how to how to guide us through this next step, and this is where a lot of disasters happen. I'll show you a couple of them now. This is a patient who was a 36-year-old nurse, super active, very healthy. She developed low back pain, didn't respond to all the usual measures. She had an MRI scan, and she has just at the L4-5 level there, one disc with really mild degenerative changes. You can see some bulging there, and all the other discs are completely normal. So the assumption in this patient was she only's got one bad disc in her spine, and that must be the source of her pain. So she had an artificial disc replacement, so the disc is cut out and replaced by a prosthesis, and she has the exact same pain, no change whatsoever. So this is a good example of how relying on an MRI scan, which shows, yes, degenerative changes, but these are changes that are very commonly seen in asymptomatic people. So we can't assume just because we see these that it's a source of pain, and it led to a bad outcome for her. There are some MRI findings that are probably more specific and can be used as biomarkers for a painful structure. This is a cross-sectional image at the L5-S1 level. You guys can't see my mouse, can you? Can you see the mouse on the screen?
Yeah, just barely.
Okay. Well, anyways, hopefully you can appreciate that that there's this area of whitish accumulation here and here, and these are in the joints of the spine, and the white is inflammation. In this case, there's effusions. So there are occasional patients you'll see that in addition to normal sort of degenerative wear and tear type changes, you'll see these inflammatory changes, and these are probably a more specific marker for symptomatic problem in the spine. Unfortunately, these still can be seen in asymptomatic people, but the prevalence is higher in people with low back pain. This is another example here. If you look down at the very lower part of the image, you'll see this whitish discoloration. It's in the bones adjacent to a very degenerated disc. So disc degeneration by itself, again, is not a specific marker for a symptomatic disc, but when discs also have this evidence of inflammatory change, it probably is more specific for an actual painful disc. So those are a couple examples of MRI sort of biomarkers that may be more helpful in terms of selecting treatments, but those are not seen that commonly. Most patients do not have these. So sometimes people will then turn to injections to try and localize the source of pain. There's a number of different types of injections that can be done. We won't go into them in detail, but they basically fall into two buckets. One is we're injecting local anesthetic into some specific structure in the back to see if pain is relieved. If it is, we assume that it's a source of pain. The other is to provoke pain in some way by injecting a structure and see if that reproduces the patient's pain. And that's another commonly used method to try and diagnose a structural source of pain. These are problematic. I'll sort of skip through this one, but this is a sort of a complicated study, but basically showed that you can inject completely normal structures in a patient with a known source of pain, and they have the same response as if you injected the thing that you know is a source of pain, probably due primarily to placebo responses. Also, pain injection results are highly correlated with psychologic distress. So the more distressed a patient is, the more likely they are to respond to one of these injections. So again, raises a question about the utility of using them to identify painful structures. This is an example of a patient who had treatment based upon primarily upon injections. This is actually UCSF faculty member, very active, healthy person. She developed back pain. This is her MRI scan, which is essentially normal for age. There's some very mild degenerative changes. She underwent this test, a diagnostic injection called discography. If you look over on the left-hand side, she then, based on that diagnostic injection, she had an artificial disc replacement at the L3-4 level. That didn't work out so well. She went from working full-time to working half-time. She then had another discogram, had more surgery. Now she's had 2 artificial disc replacements. She's not working at all. Pain's no better. She went back for more surgery. This time she flew over to Germany to have additional surgery. Now she's got 4 disc replacements in her back, and she's spending 23 hours a day in bed. This is a real tragedy that could have been avoided. So here's our research challenge. I'll just end with this, is that what we're trying to do here is to really define the patient phenotypes that predict who's going to respond to treatment. And we're looking at many different types of data in order to define these phenotypes. We're being funded by the NIH through, I won't go through all these different arrows and logos here, but we're basically being funded by the NIH through what's called the Backpack Research Program to try and define phenotypes. It's going to allow us to personalize treatments for low back pain. We're doing this with 2 different studies. One is a traditional in-clinic study where we're doing what we call deep phenotyping on a cohort of 400 patients, and we're collaborating with a number of different UC sites in doing this. And we also have an innovative e-cohort, which is a siteless study based using the Eureka platform, which has been developed here at UCSF, again with the same goal, but leveraging digital data, including electronic health records, to develop these phenotypes. Some of the tools we're developing and for use in this study include sensors that can more precisely characterize the biomechanical abnormalities, patients with low back pain, looking at novel MRI methods that can identify more precisely sources of pain using MR spectroscopy, a variety of other sensitive measures that are not used clinically currently, and functional brain imaging, which is hugely important in assessing these patients. And then finally, we're using various sophisticated tests of pain processing. This is called quantitative sensory testing, where you use very carefully calibrated instruments and then measure different aspects of how patients respond to pain. And then the other thing we're doing is we're taking all this data that really is coming from multiple different sources and multiple different formats, and harnessing all the machine learning tools that have been developed now, and it's enabling us to really develop better translational models. And we're doing all this as part of a nationwide consortium. Eventually, we'll have actually many thousands of patients in a database that we'll be able to apply all these tools to. So if any of you are interested in back pain research, we'll have a huge source of data that you can look at to answer all variety of different questions that you might have related to this. And of course, we'd love to have any of you that are interested in research that want to help us in any way and disseminate by poster presentations or papers or things of that nature, we'd love to get you involved. So this is our ultimate vision. This is our research consortium is called REACH. I won't go into the acronym because I can't even remember what it is, what it stands for, but that's what it is. So our plan is we're developing new tools to phenotype back pain patients. We're going to use those tools to build rich data sets that's going to involve many thousands of patients across the country. Then in addition to all the standard sort of data analysis, we're going to use a variety of sophisticated artificial intelligence tools to understand better the correlations within the data and how to use that to design better tools that's going to deliver our final goal of precision back pain management. So that's what we're doing in our the number of the faculty in the PM&R department are assisting in this, and I think you've had, if not lectures from some of them, I'm sure you will be over the next several months. So that's what I have, and hopefully we have about 10 minutes or so. I'm sure you guys all have lectures you have to run off to and things, but I'm available for as long as you'd like to talk, ask questions. If any of you are interested in back pain, please reach out. We'd love to have you involved with us in any way you're interested, whether it's research or coming to clinic or things of that nature. Always happy to assist.
Yeah, thank you so much for that, Dr. ONeill. Does anyone have any questions they'd like to ask at this moment?
Hey, Dr. ONeill, my name is Keith Vernon. I'm a first-year student physical therapist.
Oh, great.
It is, this is probably the third class at this point I've had on low back pain, and it tells me how intractable and common this issue is in the healthcare profession. And I'm wondering, really from your perspective, from the biopsychosocial perspective, how you address that, with your patients who also have that, oh, all my friends have it and I'm just going to end up having surgery and blah, 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 that those negative thoughts, how you initially engage with them on that.
Yeah, so I think in my world, the way it normally manifests is that patients come with an MRI report that describes all these things, and they assume that because they've got these things on their MRI scan that they're doomed. So that's the first step, is sort of talking them off the cliff with that, and just explain to them that these are all normal things that everyone has, and doesn't mean really anything about their prognosis. So that's one thing. And there's a whole cognitive behavioral therapy is not something that's just delivered by therapists. We all do that in taking care of patients, and sort of talking them through those and trying to steer them away and get them engaged in more constructive thought processes. I mean, that's something we all have to do. It doesn't really matter what area of medicine you're in, you're going to be faced with that. So I think it's mainly around patient education. And I think, just the unfortunate thing is it just takes a lot of time. You have to sit with the patient and really spend time talking to them. And that's not something that our system is very good at providing us.
Thank you. I appreciate that.
I like your shirt, by the way. Never underestimate an old man. I should have one of those.
Dr. ONeill, thank you again for the talk. So I understand that you have kind of like a unique educational background, being certified in internal medicine, anesthesiology, and pain management.
Yeah.
And I was wondering how you think that background, maybe relative to somebody with a background in PM&R or orthopedics, might be better or less well equipped to kind of do what you do clinically treating back pain, or what the research that you do about it?
Yeah, so I think, you know, in my particular case, you know, I just sort of had a hard time deciding what I wanted to do when I was in medical school. So I liked the, I felt that internal medicine was sort of the most intellectually engaging. And it seemed like a default for me. So I went into that, and then I realized that I wanted to do something that maybe was a little more active. And my father was actually an anesthesiologist, and I thought at the time, well, I was interested in critical care. And so I thought I'd do anesthesia and do critical care. And then I realized once I got into that, that the critical care really was sort of morphing into a pulmonology-based specialty. And I sort of just fell into pain management. It sort of, for me, offered a nice mix between the cognitive and procedural skills. I don't think it matters what direction you come from, as long as you're the type of person that is, you know, wants to be holistic. You know, for example, in Germany, orthopedic surgeons are also pain management. So they do surgery, but they also do, you know, more traditional pain management type things. We're actually collaborating with an orthopedic surgeon from Germany in a project we're doing. So I don't think the background necessarily is so important. It's more the ability to think holistically about these problems. I think personally, I think PM&R, I mean, I took a roundabout approach to it, but I think PM&R is probably the best entry point. But you know, I've seen, you know, not quite a few, but some orthopedic spine surgeons that are really holistic, and you know, sort of think through these things. That's mainly been sort of old school people, to be honest. Older, I have had one in particular, one orthopedic spine surgeon that was a mentor of mine, and he was really focused on rehab and not surgery. So I guess that's sort of a rambling answer, but hopefully it answered your question. Okay, thanks.
We have time for one more question. Does anyone have a question to ask? Okay, well, if there's no other questions, I think we can call it a day. Thank you again, Dr. ONeill. That was
Sure.
Extremely interesting. I think I speak on behalf of the whole group here. That it's a very prevalent issue, so nice.